So COVID pandemic gave us a little more detailed understanding of ARDS as a disease. So it's time for us to take a quick update on acute respiratory distress syndrome. So we will begin with the definition of acute respiratory distress syndrome or the diagnostic criteria. Like those of us who have completed our undergraduation and PG way back in time, most probably we are familiar with these terms called as acute lung injury and ARDS as two separate entities but part and parcel of the same spectrum of disease, right? Now, the previous diagnostic criteria for ARDS primarily focused on three things. One is presence of bilateral chest infiltrates. That's why patients are presenting with respiratory distress. Second, they spoke about oxygenation, right? Hypoxia parameters. And the third thing they spoke about was the ruling out of other causes for bilateral chest infiltrations, particularly pulmonary edema, ruling out the other causes for pulmonary edema. Most important focus was ruling out the CVS causes for pulmonary edema, right? So previous definitions, when they spoke about oxygenation, they mainly spoke about PaO2 by FiO2 ratio less than 200. Normally it is 400 plus, right? Bare minimum is 300 plus. So when it is less than 200, you could think of ARDS. So what about those patients who have bilateral chest infiltrates and they have their PaO2 by FiO2 ratio in the range of 200 to 300? That is where those patients were called as PaO2 by FiO2 ratio of in the range of 200 to 300. Those patients were said to have what is called as acute lung injury. When it is less than 200, we start calling them as ARDS. This is according to the previous definitions. Okay. And the other thing that we need to note before we go forward and discuss the current diagnostic criteria for ruling out the CVS causes for pulmonary edema, the previous criteria heavily relied on calculating the PCWP. So if you could catheterize and calculate PCWP, then only definitively you could diagnose the case as ARDS, right? So PCWP less than 18 millimeters of mercury was the requirement for the diagnosis. So that was part and parcel of the definition. If it is more than 18 millimeters of mercury, that would point towards the left heart disease or cardiovascular causes for the pulmonary edema. Right? Now, we do not follow this original approach. What we currently follow for the diagnosis of ARDS is what is known as Berlin criteria. Right? So, we follow Berlin criteria. Now, this Berlin criteria talks about four parameters. Number one parameter is oxygenation. Obviously, we are talking about, when we say ARDS, we are talking about a hypoxic respiratory failure with bilateral chest infiltrates, which is secondary to some clinical insult, right? ARDS per se is not a disease. It is not pneumonia. Pneumonia leading to development of bilateral chest infiltrates and hypoxia, sepsis leading to bilateral chest infiltrates and hypoxia, or a polytrauma leading to bilateral chest infiltrates and hypoxia. That's what ARDS is, right? So oxygenation parameters we will be looking at under Berlin criteria. Second thing we will be looking at is chest imaging to say that the entity is bilateral and not unilateral. We will be looking at chest imaging. The third criteria we will be looking at is the time of onset. Now this is particularly important, the time of onset of respiratory distress or the respiratory symptoms or hypoxia after the clinical insult. So there should be temporal correlation between the development of clinical insult and the development of respiratory distress. Okay. Now the fourth thing is ruling out other causes for pulmonary edema. This is where we are now differing from the previous version of diagnostic criteria. Ruling out other causes for pulmonary edema. Okay. So let us take a quick look at how do we diagnose or how do we define ARDS according to Berlin criteria. In terms of oxygenation, patient is expected to be hypoxic, and here also we are looking at PaO2 by FiO2 ratio, right? So when the ratio is less than 300, we consider that as a case of ARDS. So previously 300 to 200 was ALI, now even under 300 can be considered as ARDS. And here we classify based on the PaO2 by FiO2 ratio into mild, moderate and severe. Mild, moderate and severe. So Berlin criteria, apart from defining as well as aiding in the diagnosis, also helps you in classification of the severity of ARDS. So mild is where your PaO2 by FiO2 ratio is in the range of 200 to 300. So exactly mild is the one which was previously called as acute lung injury, right? Now what is moderate? Moderate is the one where your PaO2 by FiO2 ratio is in the range of 200 to 100, and when this is under 100, you can call it as severe, right? When it is under 100, then you can call it as severe. Now, this PaO2 by FiO2 ratio is calculated with CPAP or a PEEP of at least 5 millimeters of mercury, right? It is not something that you calculate without PEEP, right? With a PEEP or CPAP, PEEP of at least 5 millimeters of mercury, and you look at PaO2 by FiO2 ratio in such setting. If it is in the range of 200 to 300 mild, then 100 to 200 moderate, and less than 100, that is where you call it as severe, right? For the diagnosis, it needs to be less than 300. Then looking at the chest imaging, we should have bilateral infiltrates or opacities which cannot be explained by infiltrates or opacities which cannot be explained by either explained by consolidation or pleural effusions, right? Consolidation or pleural effusion. Okay, so it's not like a typical lobar consolidation that you're seeing and it is bilateral and you end up calling it as ARDS. It's not that there are bilateral pleural effusions present and you end up calling it as ARDS, right? So they shouldn't be, these opacities shouldn't be typical of pleural effusion or typical of consolidations. Okay. Now, the third parameter is the time of onset of respiratory distress following the clinical insult. So there should be a temporal correlation, and that is defined as less than 7 days. So within 7 days after the clinical insult, there should be development of respiratory symptoms, or if there are already pre-existing respiratory symptoms, they should get worsened within 7 days of presumed clinical insult. So this temporal correlation itself can be an MCQ point. So it's not like you had some polytrauma or road traffic accident last month and this time now you're presenting with respiratory distress. We cannot consider this. Could be still a case of ARDS, but certainly that polytrauma event is not responsible. That's not the clinical insult responsible for ARDS, right? Okay, now how do you rule out the other causes of pulmonary edema, right? Now basically we need to rule out the cardiovascular. So here the focus right now is on 2D echo rather than on the PCWP. So we don't need PCWP for diagnosis or definition of ARDS currently. Again, one more important MCQ point, right? Now this kind of simplifies. We do need an objective assessment to rule out the hydrostatic pulmonary edema, and for that echo is kind of considered more than adequate. So in the right clinical context, like patient with sepsis, developing respiratory distress, bilateral opacities, hypoxia, a normal 2D echo may be more than adequate to call this case as ARDS, right? So this is the definition, Berlin definition or Berlin criteria: oxygenation, chest imaging, time of onset, and the ruling out of other pulmonary edema causes. 2D echo for ruling out other pulmonary edema causes or separating the cardiovascular causes from the clinical insult to onset of symptoms less than 7 days. Chest imaging, preferred imaging modality I forgot to tell you is chest X-ray, but it's fine if you do HRCT for some other indication. Bilaterality is a must, right? Unilateral pulmonary edema, probably it can occur in case of flash pulmonary edema, which is often due to a cardiovascular cause, or it can occur in case of high altitude pulmonary edema, where it is like in Indian patients, it is around 60% of the patients is usually unilateral. But in case of ARDS, it is expected to be bilateral. Can that be heterogeneous? Yes, it is often heterogeneous. You don't see bilaterally uniform infiltrates or bilateral uniform opacities. Heterogeneous, but bilaterality should be there. Okay, oxygenation wise, PaO2 by FiO2 ratio with a PEEP of 5 should be under 300 to call the case as having ARDS. Okay, now this is just the Berlin definition that we have already discussed. Timing within 1 week, chest imaging, bilateral opacities, origin of edema, mainly echo to rule out cardiovascular causes, oxygenation mild 200 to 300, moderate 100 to 200, and severe less than 300. Okay. Now, what are the causes for pulmonary edema? The causes for pulmonary edema can be classified as intrinsic causes, where primarily the pathology is in the lungs, and you can classify also as extrinsic causes when the pathology is outside the lung, when the clinical insult is caused by the injury or tissue damage which is not the lung, right? So intrinsic, primary site of lesion is lung. So what are the intrinsic causes that can present with ARDS? Number one is pneumonia, right? So any respiratory infection can present with ARDS. Number two, lung contusion following road traffic accident or anything, if there is lung contusion. Okay. Number three, aspiration pneumonia, particularly aspiration of gastric content. So I can call it as aspiration pneumonitis, right? Okay. Number 4, inhalation of toxic fumes or gases. Toxic fumes or gases. These are all important causes, intrinsic causes for ARDS. Okay. Are they the main cause for ARDS? No. The most common causes for ARDS are extrinsic causes, right? So what are the extrinsic causes we need to remember? Number 1 extrinsic cause we need to remember is sepsis. And please remember, sepsis is the most common. Whether you talk about intrinsic, extrinsic, or whether you talk about overall it's the most common cause for ARDS. That's the most common cause for ARDS. And obviously among the extrinsic, that's going to be the most common cause for ARDS, right? Okay. Apart from sepsis, you have to also remember polytrauma, right? Severe multiple crush injuries is an important risk factor for ARDS. So a lot of surgeons and orthopedicians refer their cases to physicians because their patients end up developing ARDS. Okay. Then the other specific entity which can present with ARDS is transfusion associated lung injury, right? What we call as TRALI. Right. So intrinsic wise, pneumonia, lung contusion, aspiration pneumonitis, and inhalation of toxic fumes or gases. Sepsis is the most common cause for extrinsic ARDS. Polytrauma can present with ARDS, or TRALI can present with ARDS, and certain systemic infections. Apart from those systemic infections which do not satisfy the diagnostic criteria for sepsis can still present with ARDS. So these are the intrinsic and the extrinsic causes. So in case of extrinsic causes, lung is not the primary site of pathology. In case of intrinsic, lung is the primary site of pathology, right? Okay, having understood the causes for ARDS, now let us look at the pathophysiology of ARDS. Now, ARDS, we recognize it as a case where patients present with respiratory distress and type 1 respiratory failure. So that means there is hypoxia, right? That means there is hypoxia. Now, why hypoxia occurs in ARDS? So let us start with the clinical insult. Clinical insult. Now, this could be a sepsis or infection. Now, I am taking an example of sepsis itself. Now, what happens in sepsis? In sepsis, there is increased production of inflammatory cytokines, right? There is increased production of inflammatory cytokines like interleukin 1 or interleukin 10, TNF alpha. So these are the inflammatory cytokines which are upregulated or produced in large quantities in patients with sepsis. Now, all these inflammatory cytokines, they can be delivered to the lungs through circulation, and at the level of lungs, right, what they will cause? Obviously they will cause inflammation. So they will lead to recruitment of neutrophils. That's one thing. And the second thing is there is activation of alveolar macrophages which produce certain inflammatory cytokines which further recruit neutrophils. So please remember, when you talk about ARDS, you are mostly talking about in the acute phase the neutrophilic inflammation. It is not lymphocytic inflammation. It is not eosinophilic inflammation. It is neutrophilic inflammation. So alveolar macrophages are further contributing to the recruitment of neutrophils. Okay. Now the end result of this inflammation, right? What is the end result of all this inflammatory cytokines as well as recruitment of these cells? The end result is the damage. Which cell is getting damaged here? The damage to type 1 alveolar pneumocytes. Damage to type 1 pneumocytes. Now what type 1 pneumocytes do? Type 1 pneumocytes are the structural components of the alveoli, right? So you have an alveoli. So what I have drawn here is the basement membrane. So type 1 pneumocytes are the ones which are structural components. You do have some certain type 2 pneumocytes, type 2, which are concerned with production of surfactant, right? So which cells are forming the gas exchanging surface of the alveoli? It is type 1 pneumocytes, right? So if the type 1 pneumocytes are damaged, the damage to type 1 pneumocytes lead to various outcomes. One is decreased gas exchange. So that leads to hypoxia, right? Number 2 is this type 1 pneumocytes, as I repeatedly told you, they are structural components of the alveoli. So if they are lost, then this barrier between, like, alveoli are surrounded by the capillary plexus. So there is a barrier between the fluid and the alveolar space, right? The capillary blood and the fluid and the alveolar space. This barrier is formed by the type 1 pneumocyte itself and the alveolar basement membrane. So if there is damage to type 1 pneumocytes, that can lead to seepage of fluid into the alveolar space, right? So fluid accumulation in alveolar spaces. So that's one more change because of the damage to type 1 pneumocytes. Now this inflammatory cascade also causes, it is not only damaging the type 1 pneumocytes, but it is also damaging the alveolar basement membrane. Alveolar basement membrane. So there is denuded alveolar basement membrane. Alveolar basement membrane is denuded, so which also contributes to fluid seepage across this basement membrane, right, from the capillary plexus to the alveolar space. Now the alveolar space is getting flooded with fluid, and unfortunately these inflammatory markers, they are also responsible for the death of the type 1 pneumocytes. So these type 1 pneumocytes are now getting shed and they are getting released into this fluid which is accumulating in the alveolar space, right. So this leads to the fluid accumulation now starts becoming protein rich, and it is also loaded with cellular debris, right. It is loaded with cellular debris. Now this protein rich fluid loaded with cellular debris is impermeable or poorly permeable for the oxygen, so oxygenation further suffers, right. Oxygenation further suffers. So this leads to what is known as formation of hyaline membrane. This hyaline membrane is formed by what? It is formed by protein rich exudative fluid because of the inflammation plus the cellular debris, which is causing further worsening of hypoxia, right. So there was already reduced gas exchange because of the type 1 pneumocyte damage, and now accumulation of hyaline membrane is responsible for further reduction in hypoxia. That's the problem number 1, right. So we addressed why there is hypoxia. Now the problem number 2 in patients with ARDS is tendency for the alveoli to atelectase or collapse, tendency to collapse. Now this tendency to collapse is basically because of reduced amount of surfactant being present in the alveolar space. Now the type 2 pneumocytes are generally not affected. The surfactant is being produced by type 2 pneumocytes, right. They are not generally affected in the pathophysiological process of ARDS. It is the type 1 which are mainly damaged. Then why the surfactant production is reduced? There are important reasons. So the type 1 pneumocytes are the stimulants for the type 2 cells to produce surfactant. So when the type 1 pneumocytes are stretched, right, they produce certain local mediators which tell that the type 2 cells to produce surfactant. So when the type 1 cells are damaged, the type 2 cells ability to produce surfactant gets reduced. The reason number 2 is this inflammatory cytokines may not structurally damage type 2 cells, but they may inhibit the type 2 cells from secreting surfactant, and whatever surfactant that is secreted already into the alveolar fluid, that may be deactivated by the protein rich fluid that we were already talking about, right. So this protein rich fluid might deactivate the surfactant. So all things put together, there is decreased surfactant activity and the surface tension inside the alveoli builds up, and that leads to alveolar collapse, right. Okay, now the third problem that we see in these patients which also contributes to hypoxia is development of microthrombi in the pulmonary vasculature. So inflammatory cascade is already activated. So we know that in sepsis, or for that matter any systemic insult, when the inflammatory cascade is activated, we are technically prone for developing DIC. A similar pathophysiological process also occurring in the pulmonary vasculature leads to development of microthrombi, and that further impairs the gas exchange, right. So you become much more hypoxic. So this is the basic pathophysiology of ARDS, right. Hypoxia, tendency to collapse because of the reduced surfactant, and development of microthrombi. 3 essential pathophysiological hallmarks of ARDS. Okay, so this is the image that kind of compares what is happening in a normal alveoli and what is happening in a patient's alveoli where he is suffering from ARDS. So in the normal alveoli, as you can see, the main structural component is the type 1 pneumocyte, right. The type 1 pneumocyte is the main structural component, and across which the gas exchange is going to occur into the capillary plexus, and the type 2 pneumocytes are the ones which are secreting the surfactant. And the alveoli is distended or like not collapsed because the surfactant layer that you can see here is able to maintain the appropriate surface tension, not too much of it, so that the alveoli do not collapse. That's the normal situation. Okay, on the other hand, you can see the changes that are happening in alveoli which is induced during the acute phase of ARDS, right? The first change you will notice is there is slapping of the epithelial cell, mainly the type 1 cell, right? That's the one which is mainly affected. Okay. And also remember, in ARDS, the pathology is not restricted to the alveoli. It can occur in the terminal airways also. So apart from alveoli, there may be shedding of the bronchial epithelial cells, which are also coming to the alveolar spaces. Okay. Now, once the type 1 cell is getting atrophied or apoptotic, right? So the basement membrane starts getting denuded. So you see the denuded basement membrane. Now this denuded basement membrane is impairing the gas exchange, and also this denuded basement membrane is letting fluid from the capillary plexus and the surrounding tissues to seep into the alveolar space, right? The change with which we have already spoken about. Okay. Now these macrophages, which are activated because of the inflammatory cytokines, they are also recruiting the neutrophils. These neutrophils produce various other substances which can be involved in deactivation of surfactant. So whatever surfactant is produced, that can also get deactivated. And the last but not the least, again important changes, formation of microthrombi. So this microthrombi, loss of surface tension, and the type 1 pneumocyte damage, these are the essential components of the pathogenesis of ARDS. Clear? Okay. Now, having understood the pathogenesis of ARDS, it's time for us to learn about the phases of ARDS. So whatever we spoke so far, that all is happening in the first 7 days of ARDS. That's what we call as acute phase. Okay. After that, if the clinical insult is not ongoing, then patient gets into a recovery phase, right? So what are the changes that happen in the recovery phase is also we need to be aware about. So first 7 days is what we call as exudative phase. So during this phase, right, there is accumulation of protein rich exudate, as we have already discussed. Protein rich exudate, development of hyaline membrane, and significant hypoxia and a high mortality risk, right? Significant hypoxia and high mortality risk. These are the features of the exudative phase that last from the day 0 of onset of respiratory distress to up to 7 days of the phase, right? Then patient enters into what is called as proliferative phase. I can kind of call it as the recovery phase, because during this phase, most important change we notice is the type 2 pneumocytes proliferate. Type 2 cells proliferate, and that's exactly why we call it as proliferative phase. So during this phase, these type 2 pneumocytes do two important things. One is they start producing surfactant. So previously their activity was inhibited, or whatever surfactant that they produced was getting deactivated by the inflammatory cells and protein rich fluids. Now that is getting resolved because there is no ongoing inflammatory insult. There are not many inflammatory cytokines produced because of the systemic insult. You have handled that well. So the type 2 pneumocytes now start producing good amount of surfactant. So the surfactant will now be able to help alveoli retain its shape and not collapse. That's the one important change. Okay. So there is increased production of surfactant. Okay. Apart from that, the type 2 pneumocytes are capable of assuming the places which were previously occupied by the type 1 cells, and there they can transform into type 1 cells. So they start forming a new alveolar epithelial lining. So this again facilitates gas exchange, which was already impaired, right? So they can form type 1 cells. So basically speaking, this proliferation of type 2 cells is helping in recovery, right? That's why I call it as a recovery phase. Okay. Apart from this, some patients might start noticing early evidence of fibrosis. Early evidence of fibrosis. Need not be in all patients, actually not in all patients, but some patients might have some degree of early evidence of fibrosis. But the main hallmark of this phase is the proliferation of type 2 cells, which is facilitating recovery from the original insult. Okay. Now after this phase usually lasts for around 14 to 7 to 21 days, and after this patient enters into a fibrotic phase. Again, this is not seen in all patients. Most patients start showing a good recovery in the type 2 phase, or some patients might start showing the recovery in the type 1 phase itself. They are off mechanical ventilation and they might lead an uneventful life without any major sequelae of having ARDS. But some patients might get into a fibrotic phase somewhere 3 weeks after the original development of respiratory distress symptoms. Not all patients, but some patients. In this fibrotic phase, you start noticing development of significant lung fibrosis. So eventually these patients might get diagnosed as interstitial lung diseases. right? So that's the usual progression of the ARDS. Okay, now having learned the phase of ARDS, it's time for us to learn about the management of ARDS. We have already addressed the definition or the diagnostic criteria used based on the Berlin criteria. We have understood the causes and we have understood the basic pathophysiology. Now it's time for us to take a quick look at the management. Now, when you have a patient of ARDS, there are certain key principles of management that one needs to be very much aware about. Okay, equal important apart from diagnosis and management of ARDS is recognizing the underlying cause and treating it. Because if the insult that was responsible for the development of ARDS, if that is ongoing, then there is supply of inflammatory cytokines in the respiratory alveoli, which contributes or which continues to insult the alveolar surface epithelium. Now, having understood the phases of ARDS, it's time for us to learn about the management of ARDS. Okay, one simple question. What is the mainstay of treatment for ARDS, or what is the definitive treatment of ARDS? Okay, most of you would probably think of oxygen, steroids, immunomodulators, or mechanical ventilation. Those who are thinking of mechanical ventilation as the mainstay of treatment of ARDS are the right ones. Because ARDS is as much a mechanical problem as much it is a inflammatory or a biochemical problem. So yes, addressing the biochemical problem is equally important, but we also need to address the mechanical problem. Why is it a mechanical problem? We will learn about that in a minute. Okay, so let us look at the management of ARDS. Now, on your priority list, apart from ARDS specific care, will also be some additional parameters. Number one parameter on your priority list should be to recognize and treat the underlying cause. Why is it important? Because if there is ongoing inflammatory cascade, whatever may be the cause, like let us take example of sepsis. The infection is persistent, uncontrolled or unrecognized or untreated, then it is continuing to stimulate the inflammatory cascade, and the more and more inflammatory cytokines are available in the alveolar spaces, they will cause more and more injury to the type 1 epithelial cells, and that entire cascade that we have already discussed will keep running, right? So in that case, the recovery from ARDS takes longer time, or maybe condition would worsen. So recognizing and treating underlying cause is as important as institution of the ARDS specific care. Okay. Now the second parameter that is also equally important is nutrition. Because when you talk about ARDS, you're talking about someone who is going to be in the hospital, most likely intubated and ventilated for a longer period of time. And if the nutrition is compromised, maybe ARDS recovery is not impaired or affected by the nutrition, but certainly the recovery from ventilator will be affected, because if patients are not well nourished, if they continue to lose proteins, like sepsis or inflammatory states are basically catabolic states. So if they lose proteins from their chest wall muscles, then they have a high risk of becoming ventilator dependent. So nutrition is very important, and we have to understand that current evidence suggests that enteric nutrition, particularly I should use the specific word, early enteric nutrition, is the preferred mode of administration of nutrition. So we are moving away from routine use of parenteral nutrition. Parenteral nutrition, total parenteral nutrition, is only considered if enteral nutrition is contraindicated or is not well tolerated by the patient. Otherwise, even in patients with ARDS, early enteral nutrition. And when I say early enteral nutrition, it doesn't mean oral feeds, right? You can use a Riles tube to deliver the feeds, or nasojejunal tube, anything, NJ feed or Riles tube feed, but enteral over parenteral. Okay. Now the third parameter, which is again important when it comes to the management of ARDS, is early recognition and treatment of nosocomial infection. Okay, in fact, before talking about the recognition and treatment of nosocomial infection, probably I should talk a lot more about prevention, right? Prevention is definitely most important thing. So all ICUs are expected to have certain nosocomial infection or hospital acquired infection prevention policies. So prevention is important, and if at all infection occurs, then early recognition and prompt treatment is important, because patient may survive ARDS but may succumb to hospital acquired infection, right? Early recognition and treatment. Okay, so these are the basic things that you will offer to all patients of ARDS. Now it's time for us to learn what are the ARDS specific care, right? What can we offer to these patients? We can offer them oxygen, and as I've already told you, most cases oxygen and NIV are inadequate. So only in case of mild ARDS, which is according to Berlin criteria, 200 to 300 PaO2 by FiO2 ratio, not having severe respiratory distress, maybe you will be able to handle them with oxygen and NIV. Otherwise, most patients would require mechanical ventilation. So that's why I keep repeatedly saying the definitive treatment is mechanical ventilation. And this mechanical ventilation is only a bridge to recovery. So if the underlying cause is not corrected, probably patient may not recover well from the ARDS, right? So mechanical ventilation is trying to solve the ARDS induced problems, not heal ARDS, right? Okay. Now, what are the strategies of mechanical ventilation that we need to use? That itself is an important MCQ bomb, right? Now, before understanding the strategies, we need to have a basic understanding of the principles of mechanical ventilation. So, you're already familiar with this volume and pressure curve or volume and pressure loop of ventilated patients, right? So, if you plot pressure along the x-axis and along your y-axis, if you plot the volume of air that is entering during the inflation of the lung, right, you will not get a straight line. Normally, like for example, if you compare a rigid solid structure like a steel vessel, it has a fixed volume. In that, if like to start with, let us say that it is vacuum, and you start pushing air into it, right, in a vacuum space with a rigid space, if you start pushing air into it, as the volume of air increases in that space, the pressure also increases. They are kind of proportionate. So you will end up getting a straight line like this, right? As the volume is increasing, the pressure is increasing. But the lungs are not exactly rigid structures. Lungs are compliant structures. They can stretch and they can accommodate that gas. So the volume of lung is not rigid. So we do not get a straight line. What we get is a line which essentially goes like this. So as you increase initially, the volume and pressure are not much affected. Eventually, you start noticing the volume and pressure start going up. Like as the volume starts going up, proportionately pressure starts going up. And at some point of time, lungs will not be able to accommodate much volume, but the pressure keeps increasing. Like you try to increase, like for every 1 ml of volume that is accommodated by the lungs during inspiration, significant rise in the pressure starts occurring. So from this curve, this is the shape of the curve, we identify two important points. One is called as lower inflection point and the upper one is called as upper deflection point. It's called as upper deflection point, right? Now the point here is, when you try to ventilate a patient, if the pressure inside the airway is lower than this lower deflection points, that means the volume inside the alveoli is going to be very less and the alveoli become vulnerable for collapse. They become vulnerable for, like lower than this, atelectasis is known to occur. When it is lower than lower deflection point, atelectasis occurs. And when it is higher than the upper deflection point, right? When it is higher than the upper deflection points, what will happen? The risk of barotrauma increases, because every time you inflate lung with 1 ml of air after this deflection point, you are seeing not proportionate but significantly higher rise in the pressure, right? Lungs are not able to accommodate more air and they are building up more pressure as a result. So barotrauma risk starts increases. Now, so in case if you want to ventilate a patient, you need to keep the pressure volume curve in this range, right? This can be called as the safe zone or safe range. So your tidal volume should be in this range, which is the safest range. Your tidal volume should not exceed to a point where the barotrauma risk increases, because after that every little increase in the tidal volume means higher increase in the pressure, and your tidal volume should not be lower than this lower deflection point, because sufficient pressure is not there in the airway and collapse occurs. Okay, this is a normal story. But what happens in ARDS? In ARDS, because the surface tension is lost, right, so their lower deflection point is further lowered. And also I forgot to tell you that in ARDS the lungs and the airway starts becoming much more stiffer. So because of that, this upper deflection point is also further lower. So your ideal tidal volume range becomes lower in ARDS. So going forward, when we discuss about the strategies for mechanical ventilation, you should understand that you probably need to offer them low tidal volume than normal. Because if you give the normal tidal volume that is routinely used for the other patients, then you run the risk of barotrauma. That's one important thing that you need to keep in mind, because the airway and the lung parenchyma is generally stiffened in patients with ARDS. Okay, and because these patients are like this lower inflection point also being lowered, they are also prone for atelectasis, which is one of the important change that needs to be addressed, because when the alveoli collapse, they are not participating in the gas exchange, they are contributing to hypoxia. And if you increase the tidal volume to overcome this inflection point and open the alveoli, it generates a shearing force. So alveoli are opening and closing, which are already damaged and stiffened. So this repeated opening and closure leads to further alveolar injury. So whatever inflammatory cascade that was responsible for ARDS now is getting accelerated. So to avoid that from happening, you cannot rely on a high tidal volume. First of all, when you take high tidal volume, you cause barotrauma, and you also end up causing the further worsening of the alveolar injury. So to avoid that from happening, you need to use higher PEEP. So when you have a positive end expiratory pressure which is high, you will be able to avoid the risk of atelectasis. And by keeping the lower tidal volume, you will be reducing the risk of volutrauma and barotrauma, right? That's the strategy for ARDS. Okay, so studies were done looking at what should be the ideal tidal volume for ARDS, and there was a study which compared the tidal volume of 6 ml per kg and a tidal volume of conventional 12 ml per kg. And studies have shown that the mortality reduction was significantly higher in low tidal volume patients, right? The best evidence of mortality reduction in any intervention for ARDS comes from the low tidal volume ventilatory strategy. So it is associated with reduction in mortality. So for all patients of ARDS, we would be offering them low tidal volume ventilatory settings. 6 ml per kg. That itself is an important MCQ point. Okay, so tidal volume is sorted out. The principle behind that we have already understood. Now let us look at the PEEP. As we have already understood from the previous thing, to avoid atelectasis from occurring, we need to have a decent enough PEEP, right? And we also probably need a good amount of PEEP to achieve good oxygenation. Otherwise, reasonable number of alveoli are collapsed at any point of time. They're not participating in the gas exchange. So hypoxia can also be improved with recruitment of these collapsed alveoli into gas exchange. So that can also be again achieved with PEEP. So studies were conducted looking at high PEEP versus low PEEP. Now, what do I mean by high PEEP and low PEEP? That itself is something that we need to know. Now, when we say high PEEP, okay, so please remember, high versus low is not about an absolute number, right? The PEEP settings, we are anyway talking about more than 5, and you can go up to 24 as the need be for that patient to achieve a good oxygenation and reduce atelectasis from occurring. Whatever PEEP is required for the patient, you can use it, right? Okay, but what we do in case of high PEEP strategy is we start with higher PEEP setting. Like when you intubate and start with the ventilatory settings, you start high. So you generally start with 12 and you can progress up to 24. That's the high PEEP strategy. 24 is the upper ceiling. In case of low PEEP strategy, you start with 5. That's the bare minimum that we offer, and you can extend it up to 24 millimeters of mercury. So if you start low and then as the need be, you keep escalating, that's called as low PEEP strategy. When you start high 12 and keep escalating as the need be, then it is called as high PEEP strategy. So starting with 12 is high PEEP strategy. Now, the evidence in favor of high PEEP strategy is a bit controversial, but the Surviving Sepsis Campaign Guidelines 2021 for the ARDS recommends high PEEP strategy. Okay, so there are logics behind that, because if you start with low PEEP strategy, then you're not preventing the atelectode trauma, because you start with 5, nothing working out, patient continues to have hypoxia, then you probably escalate to 7, 9, 10, 12. You keep escalating till you find the right spot where alveoli are recruited and oxygenation improves. The problem with that is during the initial phases where you're starting low and trying to build up, atelectasis is still occurring, and that does cause atelectode trauma, right? When you start high, probably at least theoretically you can say atelectode trauma is minimized. But still, because we don't have solid evidence to say that this strategy is definitely superior to low PEEP strategy, there are studies which show that they are equivalent. That is where confusion begins, right? Personally, I prefer to start high because experience says that when you start high, even as an administrator of healthcare or ventilatory settings, I find it easier to up titrate from there if required, rather than starting from very low and then trying to up titrate at multiple steps. Okay, now there are other parameters which are used for assessing the what is ideal PEEP, because when you give PEEP, it is not only atelectasis. Technically, we cannot get to know which segments of the lung are now atelectasis, and we cannot keep repeatedly doing the higher end investigations or imaging, right? So basically, when we are setting the PEEP, we are looking at oxygenation, whether patient is able to maintain the saturation or not. If he is not able to maintain, you try to play with PEEP, right? So there are two parameters we play with PEEP when it comes to oxygenation. Parameter number one is you play with the FiO2, and parameter number two is you play with PEEP, right? Okay, so when patient is hypoxic, you have either FiO2 to raise or PEEP to raise. So which one to raise? That itself is a controversial factor, right? So there is a ARDS network trial data from where we can find out the ideal FiO2 PEEP parameters. Like for a particular FiO2, what can be considered as the optimal PEEP, and we can try to adjust according to that. So that's one approach. The other thing you can do is from the ventilator, you can get a static curve like this one, and then you can keep PEEP higher than the lower inflection point. Tidal volume is anyway already decided, that is 6 ml per kg. That's the best strategy. For PEEP, you can take one such static curve from the ventilator and identify the lower inflection point and keep the PEEP higher than that. After that, you can up titrate or down titrate as the situation demands. Okay, so where do we stand with respect to high PEEP versus low PEEP? As of now, evidence is not strong to say that high PEEP is superior to low PEEP, but surviving sepsis campaign guidelines still recommends high PEEP strategy. Okay. Now, I also forgot to tell you that there were also methods like trying to do a esophageal manometry and then look at the pressure changes, and that can be interpreted for management of the PEEP settings. The evidence of its utility is lacking, so no longer recommendable, right? Okay. Now, having addressed the tidal volume and PEEP, what are the other parameters we need to address, right? So apart from the tidal volume and PEEP, we also need to address the plateau pressure. What should be the ideal plateau pressure? Now, what is plateau pressure? It is the airway pressure, right? It is the airway pressure measured 0.5 seconds after inspiration. Airway pressure 0.5 seconds after inspiration is over, right? So basically, you're looking at airway pressure 0.5 seconds after inspiration. Now, this should be kept less than 30 millimeters of mercury, because higher than that means the airway pressure is high, it is crossing probably the upper deflection point and patient is at risk of barotrauma, right? This is the thing to achieve. Now, what about the FiO2? Because higher the FiO2, right, it is likely to create large number of reactive oxygen species in the airway, and that can be responsible for later development of fibrosis, or what is called as free radical mediated injury, right? So your FiO2 should be technically kept as low as possible. So you should be aiming for less than or equal to 60%. If you are requiring higher than that, try to play with the PEEP so that you will achieve oxygenation. Try to play with other modalities. We will be discussing about it in a bit, other modalities of ventilation, so that you can achieve improvisation in the oxygenation rather than trying to keep an FiO2 of 100% to maintain the oxygen saturation, right? Okay, so that is the basic thing about mechanical ventilation. Just a quick recap of whatever we have learned. The ideal tidal volume is approximately 6 ml per kg. So we prefer low tidal volume over high tidal volume strategy. Plateau pressure should be less than 30 millimeters of mercury, because anyway we are talking about low tidal volume, and with that we should be trying for a lower plateau pressure. If the plateau pressure is higher, again you need to play with your other ventilatory settings. Oxygen target 88 to 95% of SpO2, that's our target, and in terms of FiO2 we want to keep it less than 60%. Okay, now your strategy should also minimize acidosis, so pH should be more than 7.3. If less than that, that means there is ongoing acidosis and that can impair your metabolic functions. Okay, with respect to fluids, you need to remember that you need to maintain a mean arterial pressure of more than or equal to 65 millimeters of mercury. But at the same time, remember that fluid restriction is generally recommended for management of ARDS, because we'll talk about it. Okay, so fluid restriction is generally recommended, but you should make sure that hypoperfusion doesn't occur, hypotension doesn't occur. Overzealous diuretics or fluid restriction may be harmful. So MAP is what you will be looking at, and our target is, just like in any other condition, more than or equal to 65 millimeters of mercury, right? Okay, now what are the other ventilatory strategies and what is the current evidence, either whether it is in their favor or against it, right? So what about the recruitment maneuvers? Okay, so those of you don't know what is recruitment maneuver. Recruitment maneuvers are those maneuvers which are basically designed to transiently increase the PEEP to a very high value, like 24 plus sometimes, to recruit those alveoli which are collapsed, and after that maintain a relatively lower PEEP, but hoping that these alveoli which are now recruited into gas exchange will persist open. Right now, the evidence says that it is not beneficial. It is not beneficial and may be associated with harm. May be associated with harm. So no recommendation in favor of any of the recruitment maneuvers. Okay. What about high frequency oscillatory ventilation? Not associated with any benefit. So strict no, right? No evidence of benefit from the high frequency oscillatory ventilation. So not recommended in patients with ARDS. Okay. What about proning? Proning is currently recommended, particularly when you look at surviving sepsis campaign guidelines. Proning is recommended for moderate ARDS. Moderate ARDS, proning is recommended around 12 hours of proning per day. But keep this in mind, the proning should be done by an experienced team, not a routine ICU team, but someone who is already experienced in proning the patient, because patients who are already on mechanical ventilation, moderate to severe ARDS, hooked to multiple lines, dependent on infusions, dependent on monitoring lines. So proning might endanger the patient's situation. So it should be done by experienced team. So the evidence in favor of proning was slowly building up over several years, and COVID has definitely catapulted our understanding of the benefit of proning. So proning is currently recommended for ARDS, not the mild one, but moderate ARDS, it is definitely recommended. Similarly, you have to also remember that when I recorded my earlier version of the ARDS video, I said ECMO there is no evidence of mortality benefit. But now we do have some evidence of mortality benefit, especially after the COVID pandemic. So currently ECMO is recommended, not for every patient, but those who have severe ARDS. So for moderate, you can consider proning. For severe ARDS, instead of trying to build very high PEEP, trying to give 100% FiO2 to achieve oxygenation, better to go with ECMO, right? So in severe ARDS patients, ECMO is recommended, and mostly what kind of ECMO is recommended? Veno-venous ECMO is recommended. Veno-venous ECMO is recommended. So recruitment maneuvers not recommended, high frequency oscillatory ventilation not recommended, proning yes recommended, ECMO is recommended. Okay, what about the fluid management? I have already told you, restriction is generally advised. Why do we advise fluid restriction? It is not a cardiogenic pulmonary edema. It is not because of hypoproteinemia. It is not because of the fluid overload. The pulmonary edema here is because of the alveolar injury. Then why are we recommending fluid restriction? The reason for that is, now in case of the ARDS, at the level of alveoli, the alveolar basement membrane is denuded and the type 1 alveolar cells are destroyed. And that is why there is a fluid seepage. The barrier is reduced, the fluid seepage into the alveolar space. And it is dependent on the pulmonary vein pressure. If the back pressure in the pulmonary veins is high, then more and more amount of fluid will seep into the alveolar space. So by reducing the pulmonary vein pressure or by reducing the left atrial pressure, you can reduce the accumulation of fluid in the alveolar spaces, right? And studies have also shown that aggressive management of left atrial pressure is associated with better outcomes in case of ARDS. So that's why we are considering fluid restriction in patients with ARDS, because we want to reduce the left atrial pressure and thus the pulmonary vein pressure, so that the back pressure is reduced and the fluid seepage into the alveolus is reduced. And you might take help of diuretics. So evidence says that diuretics should be considered. Fluid restriction is recommended, diuretics are recommended. In other words, I can say aggressive reduction of left atrial pressures is recommended. Clear? Okay, but also keep in mind that you cannot cause tissue hypoperfusion. So your MAP should be maintained more than or equal to 65 millimeters of mercury. So if your MAP is going down, probably you need to give some amount of fluids, and you also need to cut down on your diuretics. Clear? Okay, what about the neuromuscular blockade? Now we all understand when we ventilate the patient, most likely we are ventilating for ARDS, we are ventilating with a controlled mode of ventilation, and a good synchrony between ventilation and the patient's breathing is essential, right? So there were some previous studies which showed that first 48 hours, aggressive paralysis of the patient using neuromuscular blockade in patients with moderate to severe ARDS is associated with mortality benefit. But after that, there were plethora of other studies, particularly one study which showed that you did not get specific benefit by putting the patient under the neuromuscular blockade after mechanical ventilation. So what should we do now in that case? One study shows that it is not beneficial. Other study had showed that there was a clear-cut survival benefit in patients who were particularly moderate to severe ARDS, who were mechanically ventilated and received neuromuscular blockade for first 48 hours. So current recommendation from the professional guidelines is selective neuromuscular blockade. So it is not routinely recommended, not a routine recommendation, but selectively recommended, in the sense those patients who are not achieving the synchrony after sedation, despite sedation, the synchrony is not there between the patient's breathing and mechanical ventilation. In them, institute neuromuscular blockade. Those who are able to maintain the synchrony, there is no need for neuromuscular blockade. So it is no longer a routine recommendation. That's the point I want to tell you. Okay, what about glucocorticoids? No study has shown any benefit, so it's a strict no, not recommended. Glucocorticoids are not recommended for the management of ARDS. Though used left, right, center by many practitioners, evidence clearly show that it is not associated with benefits, may be associated with harm, so it is not recommended. Clear? Okay. So this is one Harrison table that summarizes all the essential things you need to know about the management of ARDS, starting from the mechanical ventilation, right? So level A recommendation for low tidal volume. So the best evidence of mortality reduction comes in the form of low tidal volume ventilatory strategy. Important MCQ point, right? Okay, then minimizing the left atrial filling pressures by diuretics and fluid restriction. Level B recommendation, high PEEP or open lung strategy. As I've already told you, though evidence right now is a bit shaky, still most of us prefer using the high PEEP strategy. So starting with 12 plus PEEP, high PEEP strategy or open lung strategy. Level B recommendation. Proning now recommended. Recruitment maneuvers not recommended. High frequency oscillatory ventilation associated with harm, so not recommended. ECMO now conditionally recommended in selected set of individuals. Severe ARDS with significant hypoxia. Early neuromuscular blockade for routine use is not recommended, but selective use in patients who are not having a synchrony with ventilator definitely recommended. Glucocorticoid treatment associated with harm, so not recommended. Okay. Also, there was a practice of using inhaled vasodilators like nitric oxide or epoprostenol, hoping that at least vasodilation will help in oxygenation. Studies do not support it, so not recommended. And also remember, surfactant replacement therapy or other anti-inflammatory therapy like use of NSAIDs and all have not shown any benefit, so not recommended, right? So what is recommended is particularly important. They might ask MCQ saying that which of the following strategies is not recommended for ARDS management. So they might pick up one thing which is not recommended and three things which are recommended. So this one table I would urge you to literally memorize or by heart. Okay, so guys, that brings me to the end of discussion on ARDS. I'm winding up now and I'll be connecting with all of you with my next video module.